All right, this is part 2 video, and this is again properties of dental materials, but we're going to be going into a little bit more specific of the words and the terms that we're going to use for describing different properties of dental materials and how they apply. Dimensional change is the percentage of shrinkage or expansion. We want to minimize dimensional change for accuracy. Impression materials are an example of where it's important not to get any dimensional change. Different impression materials can have some dimensional change occur during setting. It can be physical dimensional change or chemical dimensional change, and there could be a loss of water. And we'll talk about that a little bit further when we get to some other terms related to impressions. A dental example of dimensional change can be for our plastic tooth restorative materials. So when we polymerize the restoration to set the restoration, whether it be by auto or photo polymerization, then there can be some shrinkage that occurs at that point, and that can affect the accuracy of the restorations and the longevity of the restoration, because if there's any accuracy or if there's any voids around the margin, even microscopically, then the restoration is not going to last as long. With dimensional change, we're going to have some expansion and some shrinkage. So in this particular picture, we have expansion. We want to make sure that the dental materials that we're using don't expand and don't shrink just within the oral environment. We know that there's going to be some with thermal dimensional change, which we'll talk about in a few minutes, but just as a property under, exact conditions, we don't want expansion, or under mouth conditions, I should say, we don't want expansion. That's a positive percentage of the original length or volume, and we use that to compare materials. Going back to our alginate impression material example, we are looking at a chemical irreversible reaction. Once we mix the powder and the water, we can't get that back to its original shape. So it's irreversible chemical reaction. And when we store it in water, the term for that is imbibition. So water stays in or makes it swell, and there is some expansion at that point. Remember, when we use alginate as an impression material, we have to add the retarder, that is sodium phosphate, so NaPO4 star star star. That first chemical reaction allows us to work with it in the bowl, and then the second chemical reaction allows the gelation to occur, or it to turn into a gel, from like that soupy mix to a gel. There are two properties. Syneresis, which is when the impression is stored in air, it loses water, so it shrinks. And then there is imbibition. When it's stored in water, it takes up water or it swells. So those are very important for you to know. With gypsum or dental stone products, we have some expansion that happens on setting. Remember, our initial setting is the loss of gloss, and then it gets warm. There's an exothermic reaction because it gets warm as it's setting, and there is some expansion during that time. It's an irreversible chemical reaction because remember, we're mixing powder and water together and we can't get those back. So another dental example is stone setting or stone products. Thermal dimensional change is related to heat expanding a material or cold shrinking a material. We want minimal percentage of shrinkage or expansion for accuracy. So if there's heat involved while processing, that can make a material expand. Even polishing can create some friction or heat and make a material expand. Foods that someone eats, we need to be mindful of the fact that they're going to be using these dental materials in their mouth later on for chewing and eating, and they're going to come in contact with heat and cold that are going to transmit temperatures to the dental materials in the mouth. So heat causes change with expansion, and cold causes change with shrinkage. So keep those star, star, star. Make sure you know those. Now we've talked a lot about percolation, and that being related to thermal dimensional change, that expansion under heat and that shrinkage during cold allows there to be a space in between the filling material and the tooth itself. So when someone drinks hot or cold beverages, eats hot or cold foods, there's a coefficient of thermal expansion differences between the tooth itself and the restorative material. So it could be composite versus enamel, or amalgam versus enamel or dentin, but it's related to thermal dimensional change of materials and the tooth, allowing the fluids to move in and out around that restoration. When you have a restoration and a tooth expanding and contracting, it creates space where bacteria and saliva can enter the space. That can cause micro leakage and recurrent decay. And remember, sometimes that space is filled with corrosion, which kind of fills it and keeps it from percolating as much, from the fluid going in and out as much. But that's related to percolation itself, is related to thermal dimensional change and the space that is created when the temperature differences are present. The result of percolation can be pulpitis. The nerve gets irritated with that change in temperature and that space opening and closing up from hot and cold beverages or foods. Temperature change creates the space or shrinks the space, and then bacteria can get into that space. The contraction and the expansion irritates the pulp, can cause recurrent decay. You can see here when there is some friction of you biting and there's stress, that it can actually fracture the tooth as well. A positive with amalgam, so this is where we get to the corrosion part, is the silver tarnishes around an amalgam and corrosion fills the space between the filling and the tooth. So I know a lot of people don't like amalgams, don't use amalgams, but that is one of the positives, is the amalgam itself has some silver in it, and it tarnishes and fills that space with corrosion. So you don't get as much percolation, which is why we can have a really rough looking amalgam in the mouth, but there's not recurrent decay around it. It just doesn't look great. Thermal conductivity has to do with the rate of heat flow and how fast heat moves through something. It moves through metal fast, it moves through plastic slow. So a base can slow down or be a barrier to heat flow. So sometimes under a filling, we can put a base under a filling which would slow down or be a barrier to heat flow. Even an upper denture that's covering the tissue, plastic, it will go through a little bit slower. It might go through a metal framework for a partial a little bit faster to the tissue, so that might conduct in it, the patient might register something hot as hot quicker than they would if they took a drink of hot coffee or ate hot food with a denture covering the palatal area. So thermal conductivity has to do with the rate of heat flow and how fast heat moves through something. Moves through metal fast, plastic slower. A denture or appliance can slow heat transfer. Patient might not realize how hot something is or how hot a liquid is until it gets under a denture and scalds the patient. So that plastic from a denture can minimize the heat, how much heat they feel. The rate of heat flow, gold is greater than enamel or dentin, so they're going to feel heat through gold faster and more than they would through just enamel or dentin. Like we were talking about with the denture example, the denture would be covering the palatal area, and it is a methyl methacrylate plastic, and it's not a good conductor. It's a poor transfer of heat, which is a good thing in the fact that it's not going to immediately scald the palatal area, but it can get underneath, and when it gets to the back of the throat, it can be too hot for the patient. So we've got to be careful with the thermal conductivity of the different products and warn the patients that they need to be careful of temperatures. Porcelain and cement, depending on the thickness, and composite are all similar to tooth structure, and they are related to post-operative sensitivity, tooth sensitivity. If there is a tooth that's going to be sensitive, heat transfer or even cold transfer is going to go through a gold crown, a little faster because it's metal. It will go through these different materials, the porcelain, cement, depending on thickness, and the composite a little bit slower, but they still can conduct some heat transfer or some thermal conductivity to the teeth. Now, an electrical property that you will get is a galvanic shock. Galvanic is Galvanic, shock. It's the zing that happens when two dissimilar metals hit together, and it sets up an electrical charge. This is kind of the shock. I don't know if anybody's ever been biting their food and hit a piece of tin foil. The shock that you get from biting on tin foil is similar to two dissimilar metals that are hitting together and setting up an electrical charge. If a patient tells you that they feel like they're getting a zing, then you need to take a look at what dental materials are in opposing teeth that could be setting up that electrical charge and giving them that zing. So galvanic shock is that shock that you get, but it is called galvanism. So both of them mean basically the same thing. Presence of dissimilar metals in the mouth, and the patient experiences pain, and they even will say that they have a metallic taste. So it'll be kind of like if you licked a battery. I don't know, I used to do that when I was a kid. But anyway, you get a little zing from that. So two dissimilar metals oppose each other. The saline in the saliva is the conductor. The metal corrodes. It loses particle into saliva. It sets up a little electrical charge like a battery in the mouth. Long-term effect of continued galvanism is corrosion, and that corrosion is continued over time. Gold doesn't corrode, amalgam does. Symptoms of galvanism or a galvanic shock, you'd get that shock, but galvanism in general is the metal taste, a pain on biting. It feels like there's a little shock or a little charge in the mouth. So that's galvanism. Star, star, star. That's another one you need to know. I mean, you need to know everything, right? But this is another one that should be higher on your list to make sure you have this straight. We've talked about the oral environment being a harsh environment. So we're going to get some corrosion with fillings, in particular amalgam fillings. You can see in the picture here, we live in Michigan, so we have a harsh environment. So we've got corrosion on the vehicles, we've got corrosion on some of the amalgam fillings. Corrosion of dental amalgam causes pitting in the restoration, and the patient actually loses substructure, so area underneath or around the filling. That causes the amalgam to ultimately fail. Now, at first, corrosion products go into the percolation area and they give amalgam a positive for a while, positive related to corrosion. But there is loss of metal, there's roughness and pitting, it goes deeper in the structure. There can be galvanism experienced between the amalgam and different restorations. And over time, just that percolation and that corrosion starts off as a good thing, but then it can cause recurrent decay. Corrosion is something that happens deeper. Tarnish is similar to corrosion, but it's a surface reaction. So the dental amalgam reacts with sulfides and chlorides that are in the saliva. There are foods and other chemicals that affect the surface of the metal restoration. It's a surface reaction. There's a change of the O2 on the surface that leads to corrosion or loss of metal. Solubility has to do with, will the materials dissolve in the mouth? So when we're talking about cements, and in this picture, we're talking about, or we're looking at grout. Will grout dissolve within the shower? Will the cements dissolve in the mouth? So cements have a certain solubility. Zinc phosphate, which is one of the mid-level cements that is used for cementation of a permanent crown, is a moderately soluble cement. Temporary cement is more of a highly soluble, so it washes out with water. When I'm giving you the example of my crown number 14, I've told you how it's cemented in there with temporary cement. And if there was any space around that crown, like the crown fits very well for it to be in with 12 years with temporary cement, because temporary cement is soluble and it tends to wash out near the edges, which would allow fluid or saliva or bacteria to get up underneath that crown and cause decay underneath the crown. So we have to look at solubility as a property, and that has to do with will the material dissolve in the mouth. And we want materials that don't dissolve for more permanent restorative work. So in the top picture we have our crown example. So the crown has lost some of the cement around the edges due to the solubility of the cement. When we're cementing something permanently, we don't want there to be much solubility with that cement. We're going to get some, and we don't want there to be much solubility. It's got to be compatible with the oral harsh environment, and it's also got to be compatible with the material that the crown is made of, and we'll go into that a lot more when we get to cements. The bottom picture is composite, so where there is composite material that's been lost due to solubility. So we want to pick good materials for the spot that the restoration is and for the material that we're using, so that it doesn't wash out. Here we're talking about absorption and adsorption. We listed both of these in our definitions that we did in class the other day. Absorption is taking up of fluid within a solid. So this was our sponge example, or paper towels wiping up, absorbing water. Adsorption is taking up fluid onto the surface of a solid. This is like condensation beads that stay on the surface. Here's a picture of adsorption with the gel on the surface, and absorption when we're absorbing into something. All right, we want a material that is wettable. Like say for example, somebody has an upper denture. The acrylic that we use in dentures is highly wettable because we need the saliva to be able to spread across that surface and not bead up on that surface. So we have wetting agents. We have soap that reduces the surface tension of water so water can spread over the area. We have wetting agents that reduce the surface tension to make things spread. So low wettability has to do with poor wetting, beads of water on a waxed car, like a waxed car. So that's low wettability. Low wettability is less desired in dental. We want things that are easily wettable or highly wettable. If we have a low contact area, like you see on the good wetting side, if we have a low contact, then that means that the bead of water is spread across. So dental material, we want the wetness or the water to spread across the surface and not be beaded up because it's going to be wet all the time. So good wetting is high wettability with the water spread across the surface. Poor wetting is a big bead of water, a high contact angle or a large contact angle, and that's like your bead of water on a waxed car. We don't want that. We want the water to be able to spread across the surface, or the sealant gel material to be able to spread across the surface, the sealant material to be able to spread across the surface. We want a low contact angle and something that's easily or highly wettable. So we want sealant material to spread across the enamel. We want saliva to spread across everything in the mouth, but particularly enamel. We want saliva to be able to spread across denture material. When we use soap or detergent, it increases the wettability. And wetting agents reduce the surface tension and allow things to spread across the surface. So make sure you know that we want something highly wettable with a low contact angle. That means it's spread across the surface. If we have a high contact angle, that means it's beaded up, and we don't want that. All right, this mechanical properties of dental materials has to do with stress equal to the rate of force in an area. So the picture that we have is this chunky heel versus this spike heel. The chunky heel is going to have a more static or slow load, and the dynamic or the spike heel is going to have a faster load. So static stays the same. We have a slow rate of load. They have a lot of materials that they test in a lab where they have a wider something biting against the material, and they have a more dynamic or fast biting against the material to see how the material is going to hold up to the stress and the force in that area. Dynamic is the opposite of static, so it's a faster rate of load, and it's faster and in one spot, like it's more concentrated in one spot. If we can spread the load out, then more surface area is going to displace the force over a larger area. Stress is equal to the ratio of force per area. So like think about a pencil point. We can be more precise with a pencil point versus, like if we have a blunt eraser. Homework versus time. More time, less stress. Less time, more stress. So when I'm in class and I can tell you that, it relates a little bit better. But static, slow load, chunky heel versus dynamic, fast load with the spike heel. And when we put the static versus dynamic load into play in the mouth, if we have this cusp in the picture on the left, if we have that cusp and we are absorbing a lot of that force to that area, we're likely to break that corner of the tooth off. Then we have to completely cover it with a crown because obviously we have a filling in there. There's going to be percolation between the filling materials, so we're going to get some contraction and expansion, temperature, and force related. If we put a crown on there that completely covers that tooth, then we're going to have more of a slow or static load because the forces are going to be spread out. Compressive or compression stress is when material is squeezed by forces coming in on all sides. So this is the filling material as we chew. Most dental materials do better with compressive or biting forces versus tensile stress, which we'll talk about in a few minutes. Here's a picture of compression stress with the cusp of the opposing tooth hitting right onto the lower tooth on a big filling, and it may be breaking a piece of the tooth off, it cracking and irritating the pulp in number 2, it going into the pulp and causing pulpitis, probably irreversible pulpitis in picture 3 versus maybe reversible pulpitis in picture 2. And then in number 4, it's showing that compression stress going all the way through and fracturing the tooth. Tensile strength has to do with the material being pulled apart or stretched. So think about when material is pulled or twisted, like when we twist and pull an impression tray out of the mouth. Impression material is not going to hold up well to the tensile twisting or pulling of that impression out of the mouth. So that's why we want to do it with a snap, because it's only got a certain limit that it can go before it is not going to be accurate anymore. We talked about tensile strength and twisting and pulling of the impression tray out of the mouth. The bottom picture shows some abfraction. When there's tensile stress or some pulling and twisting of the tooth itself, even just with the way that it bites, there can be some abfraction or loss of enamel in that cervical area due to tensile stress. Shear stress is when there are two materials that are bonded together. There's force going opposite ways on each side of the bond. So one of the best examples that I can think of, and it's in the next slide, but I'll tell you about it now, is an orthobracket. So when you bite the teeth together, you've got a bond underneath the orthobracket, and there's a shear stress. It can't take much stress. That's why a lot of kids will lose their orthobrackets. So shear stress is testing the strength of two materials bonded together, and the forces are going opposite ways on each side of the bond. So the tooth is going one way and the orthobracket is going the other. So when putting on orthobrackets, we need to make sure that the tooth on the opposing arch is not hitting the bracket. Because if a maxillary tooth or a mandibular tooth, depending on where it's at, if a maxillary tooth contacts a mandibular bracket, it will exert shear stress. And orthodontic cement doesn't hold up well to shear stress. You're going to end up losing a bracket. So strain is a measure of deformation per unit length. So you have material, you measure the material, you apply stress. How much longer it gets is strain. You can overstress elastic materials and they give out. And I like to think about this like our ponytail holders. And I have a ponytail holder, and it's real tight at first, and then it gets a little bigger, still works, a little bigger, still works, a little bigger, still works, because strain, strain, strain still works. But then at some point it just gives out, and it's not going to do anything. I might as well tie dental floss around my hair at that point. But we can overstress the elastic and the material will give out. The stress within the object is unable to resist the force, deformation occurs, and the object has undergone strain. And as long as it can go back and it can still do what it was supposed to do, you can still use it, but there comes a point when it's no longer usable, like that ponytail that I told you about. So strain is equal to deformation per unit length as a result of force. It has nothing to do with heat. A better dental example is strain within an amalgam. You're going to get creep, and eventually you're going to get breakdown and failure of that amalgam. So we don't want the creeper. Creep is a measure of edge strength, and the edges have to be resistant to marginal fracture. In amalgam, we're going to learn a lot more about amalgam later, but in amalgam, a higher copper content in amalgam so higher than 6% copper, gets rid of a phase that we call the gamma 2 phase. That gamma 2 phase will lead to more corrosion and thinner margins. We're going to talk about that a lot more during the amalgam portion, but it's a reason why some amalgams would creep and move a little bit more. And remind you, this is all happening kind of microscopically, but it's a reason why some amalgams would move and change a little bit more than others. There would be more strain than others, and it has to do with the composition of the different amalgam. So amalgam is like a mixture of materials, and it has to do with the mixture, the certain percentages of the different parts of the mixture. If you have a higher copper content, higher than 6%, it gets rid of a gamma 2 phase that occurs in amalgam that leads to corrosion and thinning of margins. So you get less strain, the material, it holds up better. But we'll talk about that lots more. I wouldn't quiz you on something like that until after we talk about amalgam. So elastic modulus is a measure of stiffness. When we have high stress, so lots of stress or force put on a material, and there's very little strain, then it's very stiff. If we have a low amount of stress put on a material and there's a lot of strain, then it's not going to be as stiff. So elastic modulus is a measure of stiffness. High stress, low strain is a very stiff material. Low stress, lots of strain is not as stiff of a material. Dental examples of elastic modulus are impression materials have to be less stiff so that we can manipulate them around better, and then restorative materials should be more stiff to prevent large deflection when stress is applied. On this slide, it's showing the stress-strain curve. We can use this for all of the mechanical properties that we've been talking about, the compression, tensile, and shear strength. Under the stress side, we're measuring that in megapascals. So MPAS is the abbreviation. So megapascals are equal to 1 MPa is equal to 145 pounds of force or stress per square inch. Star, star, star. 1 MPa is equal to 145 pounds per square inch of stress. Now, as you go up the stress-strain curve, starting in the bottom corner, we go up to the first dotted line. That is our proportional limit. That's our proportional limit. And our proportional limit is where the stress and strain is no longer the same. It's not as stiff. The elastic band doesn't quite bounce back. There's more stress versus strain past this point, so past the first little dotted line. The next line up at the very top, so it comes from the left, the UTS, and up at the very top is the yield strength. So it deforms fast on the way to breaking. It doesn't go back to the way it was. So our second line that doesn't meet another line is the yield strength. Deforming fast on the way to breaking. It doesn't go back to the way it was. This one at the very end over here is ultimate strength. So the very last line going up, straight above my head right there, is the ultimate strength. The ultimate strength is the point where the material busts. The ultimate compressive strength, the ultimate tensile strength, the ultimate shear strength. is that very end. After that it breaks and it's no longer useful at all. But in between there, we've got the stress on the side, the strain on the bottom. The first marker we come to is the proportional limit. Once it starts to go up, the proportional limit, the stress strain's no longer the same, it's not as stiff, it's gonna have a little bit of, like a rubber band's not gonna bounce back quite as well. There's more strain versus stress. Then we have the yield strength, where it deforms pretty fast on the way to going to the ultimate strength at the end, where it actually breaks. And I can show you that in graph form with it labeled, so remind me during class and I'll let you take a picture of that. So as long as the material can go back to the original shape, it's that initial first line up until where the points meet. As long as she can go back to original shape, it's the elastic modulus. Everything's working just fine. The proportional limit is when the stress strain is no longer the same, it's not as stiff, the elastic rubber band doesn't bounce back, and there's more strain versus stress. We've reached our proportional limit. Yield strength, it deforms fast on the way to breaking, it doesn't go back to the way it was. That's your yield strength. And the ultimate strength, the ultimate compression strength, the ultimate tensile strength, the ultimate shear strength is the point at where the material can take no more and it busts. Some dental examples are compressive strength of amalgam, the point at which amalgam will bust under compression strength. Amalgam has some malleability. I think of malleability, I think of the like clay, or something like Play-Doh that I can put in my hand that's malleable. But there is some malleability to amalgam that allows it to absorb when you have compression strength. But there is a point where it will bust under the compression stress. The tensile strength is the point the amalgam will bust under twisting or pulling, so elongation. Shear stress is the point where amalgam will bust under shear stress. You've got two bonds or two areas that are moving in opposite direction. So brittleness. Brittleness is when a tooth has no blood supply and it becomes brittle and it breaks. It can break because of compression, which is a measure of malleability. Too much compression on something that's brittle is going to eventually have it break at a certain point. Elongation or stretching is a measure of ductility or tensile stress. So measure of ductility. Gold can stretch pretty easily. When you heat up gold, which if you're making a piece of jewelry, you're going to actually make it liquid, you're going to heat it up that much. But gold can be stretched. Gold can easily be stretched. There's a lot of ductility to gold. There is some compression strength and there is some measure of malleability to amalgams or gold. The amount of deformation as a percentage before the material busts has to do with the measure of ductility, the measure of malleability, and the actual yield strength at which it busts or breaks. So dental examples are finishing the margins of gold. Gold is a ductile metal. It's got good compressive strength. So we've got a lot of room for compressive stress and pressure to be applied. It's malleable. In fact, they do gold foil fillings where they take gold metal in sheets and they're able to pack it into like a class 5 area and do a gold foil filling restoration. Dr. Nancy will tell you about gold foil fillings that she had to do before graduation and how much she loved them. They take solid 24 karat gold and then they cold work it to become 18 karat and then it becomes harder. We'll learn a lot more about that during our crown and bridge section. Composites under stress can fail as a result of a brittle fracture. So brittleness is just another property that dental materials have. Some materials are more brittle, like composite, versus gold is not quite as brittle. It has a lot of malleability to it, and it can take a lot of pressure and compression strength, which is why it's a good So resilience is the total energy to permanently deform a material versus toughness is the total energy required to fracture a material. So you can see in the stress strain curve, resilience is lower. So I think about resilience, even if you think about a kid, like kids get exposed to a lot of things. They're very resilient to a lot of things. But then there comes a point where, as resilient as they are, like they just can't take any more. They can't take any more stress, strain. It's beyond what they can physically, mentally take. Their toughness gives out. They've used up all their energy and they're just done. So that's kind of like the toughness, the total energy required to fracture the material, the total energy or total stress, strain to break the kid. I think about this, and, like total energy to permanently deform, total energy to totally fracture is at the end. So resilience versus toughness again. Resilience is the same total energy to permanently deform, but toughness is a different total energy to fracture. It's lost its shape but continue to stretch before it gets to that toughness area where it breaks. The dental example is two tooth-colored materials. They have the same resilience, but one's tougher. They have the same energy to permanently deform, but more energy is needed to bust or fracture one versus the other. If you think about an anterior composite, especially the old-time anterior versus posterior composite, the anterior composites couldn't be used in the posterior because they couldn't stand up to the stress and the strain. They would have same resilience, but it couldn't be used in the posterior. Posterior is different makeup, different filler. Remember I was talking about the cake batter. It's different filler. So more filled is going, and with different sized particles, is going to be tougher. There's going to be more total energy required to fracture the material than if we have a less filled material. So there's differences in materials. They have the same resilience, but one is tougher than the other. And yay, the last slide. The Knoop hardness scale is a scale of hardness. If a material is hard, it strongly resists indentation by another hard material, like a diamond. We use a diamond burr to cut enamel because diamond is stronger and harder than enamel, even though we know enamel is 96% mineralized. So the Knoop hardness scale, star, 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 is a scale of hardness, how hard a material is versus another material.